Good evening, Jambo and Karibu. Welcome to the final webinar on communication. My name is Shabnam Molidina, and I am an advanced practice nurse and nurse practitioner currently working on my doctorate in nursing practice. We are glad you are here. Tunashukuru na furahi sana kuona wote hapo. As a reminder, the only way to interact us through the three tools listed: chat, where you can share ideas and feedback with other webinar attendees; raise hand, where you can share your experience; and Q&A, where your questions will be answered live during this webinar. Now, let's have everyone introduce themselves using the chat features. Click on chat and type in your name and specialty. As everyone is doing that, I did like to share that today I will be joined by Miss Regina Alaberry, a doctorate student in communication studies at the University of Memphis in Tennessee. And we will hear from Dr. Joy Goldsmith, who is also in Tennessee. Thank you for everyone for joining us this evening. Asante sana kuona wote hapo. As a reminder, for those of you who attend at least 2 webinars, you can earn certificate of communication training by completing the final assessment. We will email you a link to the final assessment, and once completed, we'll provide you with the slides, notes, and additional resources that will be shared with others. First, we will define family communication pattern. Second, we will identify difference among family caregivers types: managers, carriers, loaner, partners. Third, we will help you to build an awareness of family caregivers' communication patterns. Comfort. Comfort is an acronym that stands for 7 basic principles designed to be taught in early palliative care communications. The curriculum is based on empirically research in hospice and palliative care, including observations of interprofessional teams, meetings, member collaboration, and interviews with team members across the range of healthcare professions. This webinar will provide the content of family caregiver modules. How many of how many of you rely on family caregivers to take care of the family at home? We all do. How have you said to a family caregiver, "Do you understand?" Have you asked a family caregiver, "What can I do for you?" It is highly likely that the majority of your time is actually spent talking to the family caregivers more than patients. They look to you for guidance. Family caregivers are important because their communication behavior impact patients and outcomes. Communication difficulties are commonly reported as a barrier to an effective physician caregiver relationship. Caregivers are very stressed about talking with you. They are doing things for the first time and there is a lot at stake. The stress of disease, what the future may look like, how much they trust you, of this impact the ability to communicate with you. And most importantly, you are asking them to communicate about things that they may or may not talk about within their family. To tell us more about family communication, Dr. Joy Goldsmith will describe family communication pattern. Asante sana, karibu sana. Dr. Joyce Goldsmith.
Great. Thank you so much. Thank you. Karibu. I want to invite everybody to think about their own family as we talk about this material and this research. It's very applicable to certainly the provider, which is why we built this material, but it's also easier to get in touch with because all of us emerge from a family system or family environment. So the system of a family is comprised of bounded individuals. They're interrelated, and they also have identifiable communication patterns that are central to the workings of that family group. The relationships among family members reveal and expose potential sources of conflict, as well as reveal variations in health literacy and ability to access and communicate about information within the family. So there are variations within the family. And also, these patterns of communication demonstrate positive or negative coping, which directly impacts patient care and patient outcomes. So, family systems are constantly interacting with everything, their environments, their situations, the people and information that is accessible to them. And families respond by adapting in some way to the stress or change that they are facing. So, as healthcare providers, you face these patterns with each family group that begins an illness journey with you under your care. So, we like to think about these dynamics as the communication climate for a family. And the climate really represents the rules and the scripts that are embodied and demonstrated for each family, just like your own family has these rules and this script. So, a communication pattern in a family is a learned behavior that has been shaped by the climate of communication in a family. A family's pattern of communication is governed by two components that create this climate. One component is conversation, and one component is conformity. So, conversation beliefs dictate what is appropriate, what is an okay thing to talk about in family discussion, and also the degree to which families spend time communicating, and whether or not families engage in communal decision making or individual decision making, or maybe dyadic decision making within a larger family. So, high conversation families communicate with very few limitations to topic or time. And we count this conversation as connection and communication that can happen in any modality, any channel, not just face to face. The low conversation family has less frequent interaction with only a few topics that are really freely discussed. So that's the conversation piece of the climate issue. Now, the conformity issue is quite different. Conformity deals with beliefs about attitude, values, how to use resources, obedience to parents or elders within a family structure. High conformity families really emphasize harmony, conflict avoidance, sameness of beliefs, and obedience to elders and parents. And low conformity families emphasize variety, difference. There can be various perspectives and dimensions to family attitudes, values, beliefs. Uniqueness is upheld, independence is okay, differing perspectives and beliefs are allowed, and conflict is not only tolerated, but sometimes welcomed in order to navigate difficult situations and include everybody's perspective in the decisions and challenges for a family. So if you have questions at this point about communication climates in family, or the conversation component, or the conformity component, please populate that Q&A box, and Dr. Wittenberg will help us navigate those questions as we go forward. So our work in family caregivers helped us understand these communication patterns that then lead to reveal 4 general categories of caregivers in terms of their communication. And the first of those 4 is the manager. So here's a quote. "I'm a nurse and my siblings are very comfortable with my role as the expert on mom's pneumonia. So that would be sort of an exemplar statement from this kind of caregiver. This family member is the self-appointed family spokesperson for the illness journey, limiting the voice of other family members in the decision-making process. So as a result, the other family members and the patient ask very few questions, are very minimally involved in dialogue about the care experience. And these caregivers, the managers, focus on very swift decision making and little discussion about the options. Time is of the essence for this caregiver moving quickly into decision making. So, things to look for as a provider, as you're sort of discerning this person may be a caregiver who is a manager, you may notice a particular caregiver really managing their uncertainty by taking control and managing the communication within the family and exhibiting a lot of eagerness to seize on a treatment plan before it may be fully explored and considered and the side effects understood. So there is a kind of a muting of the process of decision making that can, in a lot of cases, exclude other family members and what they're concerned about, as well as the most important person in the care experience, the patient. So we can kind of be snowed over or fooled in a way by this caregiver because they are so good at using medical terminology. They have such facility with the language that we as healthcare professionals may make the assumption that this caregiver understands not just the language but the concepts and the impact of care decisions, care choices, treatment plans, when in fact our research has told us, has revealed that this is not the case, that this caregiver really does need a connection with healthcare providers that is trusting so that their real questions can be answered and they really can reach a higher level of health literacy to come to know the impact of the decision and maybe slow down that train of seizing upon decision making in order to reduce uncertainty. So the manager will rely on you as provider to work closely with them in helping the patient receive the most appropriate care. So, kind of push past the initial impression that this person has total mastery over the information you're sharing. Okay, that's the manager. Let's go to our second type, which is the carrier. So here's a quote we wanted to share. I was very depressed, spent many hours crying. Okay, this caregiver is coming from a family system that has very high conformity, like the manager, high conformity. But unlike the manager, the caregiver comes from a family system where conversation is low and it is not a place to process concerns, to figure out how to navigate the burdens of caregiving. It's not a place for that. This caregiver surrenders to family authority, to patient authority. So it's like the flipped opposite version of what we saw in the manager. This caregiver absorbs as much as they can so that their family system does not have to shift in terms of conformity. They don't have to do any movement. Everybody can kind of maintain what they were formerly doing before a diagnosis within the family. At least those are the perceptions of this caregiver. Communication with other family members is very limited. There is a trend of silence in this family system, and the caregiver suffers because of that, especially in the midst of caregiver burden. So, pressure to conform to what the patient wants is given priority over everything. And these caregivers welcome the opportunity to work with healthcare professionals, to disclose to staff to disclose to professionals who are specifically invested in caring for the caregiver, because the family system is not a place for this caregiver to get support. So the family environment really prohibits sharing of the caregiver burden. The carrier will seek a lot of decision making support and affirmation from healthcare professionals and clinical staff because there's just not the support within the family. Things to look for as you're working with caregivers and you think you might be in the presence of a caregiver. This caregiver is unsure of medical issues and is not a challenger, does not challenge medical information, unlike what you might see with the manager. This caregiver instead focuses readily about their own caregiving labors, their own worry, their concern that they may not have completed caregiving tasks adequately. They may have let down the patient and the family. This caregiver is very responsive and very much in need of resources you can share with them, and is also eager to share with you their own burden and receive care from you. Okay, so let's try something. I want you to take a look at this case description. Vera works feverishly documenting Sam's care and calculating their next treatment move. She also works very hard to make all decisions without consulting their 4 adult children. Both Sam and Vera agree that their children have not been affected by his illness. Vera is present at his appointments, and Sam acknowledges that she is his mommy in the care of his kidney disease. So I would like you to just try this if you want to, and take a guess at whether or not you think this is a manager caregiver, Vera, or is this a carrier caregiver? What do you think the work of Vera might indicate? We also want to remind you this is a great time to populate the Q&A for Dr. Wittenberg to look at. We welcome any questions about these two types so far, and also our just overall work in caregiver patterns. Okay, so if we look back at the Vera and Sam dynamic, we underlined some keywords here for you. So it's tricky, right? Because both the manager and the carrier are coming from high conformity families. So this case shows that closeness of these two types. Patterns of sort of protecting the family, wanting the family to just motor on and keep moving forward. But big indicator here is the underlying language that Vera works very hard to make all decisions. So the carrier caregiver, the patient is really calling the shots in the carrier caregiver. But in the manager caregiver situation, they work very hard to seize upon decision-making control. So thank you for your answers and your participation there. I now want to direct you to one of our other presenters, Miss Regina Alibert, to hear about the second two caregiver types.
Thank you very much, Dr. Goldsmith. So let's talk about the partner caregiver. That's our next type. And this quote here says, we all have different ideas on how to manage mom's pain. So that's a statement that you can hear from a partner caregiver. Now, partner caregivers, they emphasize on the patient first, and they are situated in a family that is sharing burdens of caregiving, and they're also in a family that has different ideas on decision making and support. So here, this family member benefits from the patient's advanced care planning and family-initiated internal meetings to facilitate decision-making and support. This caregiver type integrates into the care team and is flexible in changing the course of how to go about making decisions about the patient's illness, right? So when we talk more about the partner caregiver, here are things that you as a provider should be looking out for. So in the partner caregiver, in the process of the illness and the course of the illness, you might see different family members at different times, coming in during hospital visits. And you might see that, in terms of the patient, there are multiple speakers integrated in the involvement of the patient's well-being. So this caregiver, this partner caregiver, can benefit from a focus on education in preparation for care tasks, as well as planning ahead to address anticipated loss, since it takes a group to kind of make a decision on what to do next, right? So it's very important to use your skills and their interests and not just focus on one person, but the families, the family members that are interested in taking care of the patient. So the next caregiver is the lone caregiver. And here you might see someone talk like this. So how much sedation are you giving my mom? She can't even open her eyes when I talk to her. I want to stay with her 24 hours a day in case she wakes up. So the lone caregiver here has little support other than the patient and the provider for decision making and care provisions. There is limited communication, and there is weak relationships with other family members, right? So it's possible that other family members are not involved in their everyday life, or maybe some reasons due to stigma or discrimination, right? It can happen. And because of that, loner is taking that stress alone of caregiving. They can experience high stress, they experience burden, they also experience limited social support networks. That's a thing. And the focus, planning, and trust is with the patient and the provider. Now, these providers fixate aspects of physical care and commonly bypass a quality of life and social and psychosocial focus. So they don't really care about them, but they just care about the patient. And here, what we see over time is that the health of the caregiver begins to deteriorate, right? Because they're not caring for themselves. And this is because the caregiver gives their all to the patient's care and leaving little left for their own care. So let's talk about other things to look out for. You may notice that this caregiver is the only one that is there with the patient every time, right? And they also rely on the credibility of, providers to make difficult choices. And this caregiver benefits significantly from strong relationships with healthcare providers. Okay. So now let's talk about this case study. Okay. So this case study reads like this. Sharon describes deflecting other family members and friends as they call or visit, and the immense cost and exhaustion that she endures as a result of this labor. She dutifully and exhaustively carries out her partner Kelly's medical plan. Sharon's primary support comes from her bi-monthly therapy visits. Beyond this, she shares very little of her struggle and day-to-day pressures, and most especially does not communicate them to Kelly or their family. So I want you to populate the chat and put the answer in the chat. Is this a carrier or partner caregiver? And if you think either or, talk about why you think that this caregiver is a carrier or a partner. Okay. So now that I'm done talking about the career, um, the partner and the lone caregiver, I'm going to invite Dr. Goldsmith to discuss one more case study and summarize our webinar.
Wonderful. Okay, great. Good to be back. All right, so we have talked about Sharon, yes? And what's going on with the family and Sharon dutifully and exhaustively carrying out her partner Kelly's medical plan. And that's really the big hint right there. So if we see that the caregiver is doing all of the heavy lifting and enacting all the wishes of the patient, we know that we're looking at a carrier, definitely looking at a carrier. Let's look at another case. Okay, Ellen is caregiver to her husband, Alejandro, who has end-stage liver disease. Ellen is retired and has always assumed the majority of caring for her husband and managing the home. She and Alejandro live near family, but receive no communication from them. Alejandro has discomfort, loss of appetite. He was considered for a transplant, but did not fill the criteria due to cardiovascular comorbidities, which suggested he would not survive the surgery. Alejandro was referred for palliative care evaluation, and you're meeting with Ellen to learn more about her and to assess her understanding of her husband's disease. Okay, so you should know by now that the underlined words are a really big hint, okay? So, my gosh, here is this caregiver and her patient who need palliative care. And it sounds like they are in a constellation of family members, but they are not connected in any way for support, for illness caretaking, for anything. And that Ellen and Alejandro are really the partners here in this caregiving journey. And that is the earmark of the lone caregiver. When the social support that the caregiver is receiving is all coming from the patient. So I think we've got a really clear example of these types for you to think about. If you have questions at this point, do not hesitate. Actually, at any point, do not hesitate to talk to us in the Q&A, okay? This module is, I mean, we don't want to say that it's our favorite module in the comfort model, but it might be our favorite. We really have enjoyed developing the research in this module and understanding more all the time about these caregiver types. So first, we talk to you about family communication patterns, and that is what makes this a communication model. And that is how we can impact healthcare with communication science. Family communication patterns are based in evidence. This notion of conversation, high and low, and conformity, high and low. And from these two elements, we can discern that we've got 4 caregiver communication types. The manager, who comes from a family where there is a lot of conversation, but there's also a lot of conformity, which is going to shape that conversation. We talked about the carrier, who is coming from a family that shares almost no conversation, but very high conformity. So we get a caregiver who is riddled with the demands of the patient and the rest of the family. And the caregiving phenomenon for that caregiver includes very little space and time for him or her. The partner caregiver is emerging from a family with a lot of conversation, a lot of contact, but very low conformity. So there is room for difference. There is room for shifting responsibilities and shifting roles. And the role of the elder does not drive all of the decision making. And finally, the lone caregiver is emerging from a family with very low conversation, if any, and very low conformity. So this lets us know this family has little contact, little ritual, little connection and support. And so this caregiver relies in a very strong dyadic partnership on and with the patient. So the manager, going back to the first type that we shared, speaks for the patient and the family, but needs a lot of input from you, from the healthcare team, to achieve the best patient care. This caregiver has very high stress, we have found, and very high anxiety as they are taking on so much management of care. The carrier is facilitating all the decisions of the patient and taking on and carrying the burden of an entire family system while feeling unprepared to do any of it. So, whatever patterns or practices that the patient previously were performed before the illness, the carrier now adopts those practices. The carrier now will pick up the kids or the grandkids since the patient cannot, on top of all other caregiving tasks and burdens. And that is why the weight is so heavy for this caregiver. The partner caregiver functions within a family system that participates in a range of ways to support patient goals and needs. So the patient is at the center, and everybody else is reaching into that center point to try and support that patient. This caregiver is a good partner and needs communication across the family to perform caregiving. So there's a shared labor in this. And as a healthcare provider, you may see different people show up and seem to be very, very involved in the caregiving effort. So, one thing that we have learned about the partner caregiver is that there are so many involved that there is no clear story among them about the best place of care, the best place to find providers for care, that there's sort of a many cooks in the kitchen phenomenon that happens that in the end may lower the health literacy for partner caregivers because there's so many people involved that not everyone has mastery over the narrative of the illness, unlike the lone caregiver who does have total mastery. There's no competing force, there are no competing family members. There's far less, there's like no interference from other family as we will see in the other caregiver types. But there's also much less support in aiding the caregiving burden and demands. So this caregiver oftentimes will turn their focus onto biomedical physical changes in the patient, and they very much can use support from healthcare professionals in working with the patient to achieve the best quality of life for both caregiver and patient. So we want to say this is a tall order, right? Like you're providing patient care, but we're suggesting that you're also recognizing the labors of the family caregiver, because without the family caregiver, the patient is going to be without support at home, and support at home is becoming a larger and larger trend in healthcare. So thank you for recognizing that caring for the family caregiver is imperative in the work of the healthcare system and the work of healthcare providers. We want to thank you so much for attending our final webinar. And I want to say a few things about the 2 prior webinars that we've presented over the last 2 weeks. Well, 3 weeks, including today. So tomorrow, we will be sending an email with the course assessment. If you would like to achieve the certificate of training for this series of webinars, please view at least 2 total webinar recordings posted and complete the final assessment indicated in the email that you've received from Communicate Comfort. Once you complete this assessment, we're going to send you PowerPoints of the slides for all 3 webinars and some additional resources. So remember, you may receive your certificate of communication training only if you view or attend 2 of the 3 webinars, one of which is today's presentation on family caregiver types. As always, we are eager to receive your questions, to read and understand your comments and your feedback, either through our Q&A feature, or you are very welcome to reply to our email address at Communicate Comfort. Asante Sana, thank you so much, and good night.